Hello everyone, I'm Brian Rock. I'm the Clinical Director at Kooth, and I'm going to be talking about the role of digital early intervention in whole population pathways, embedding mental health pathways to address service demand. And after Nathan's talk, I have to say, follow that. Really brilliant. This is something a bit different, but I think something that most probably affects all of us, if not most of us, at some point in our lives, and that is really about mental health provision and mental health care. Just by way of sort of some context, I'm a consultant clinical psychologist. I worked for 26 years in the NHS in complex adult mental health care services, and one of my most rewarding experiences was establishing a primary care service across East London to really act as a bridge and a link between IAPT and secondary care, and everything you said about secondary care services and the relationship with primary care and the different ways of operating and requirements is absolutely true. And just the benefit of proper joined-up care. And actually, I think there's been a sort of a widening, developing array of choice, which in many respects is a good thing, but in other ways actually can be very, very challenging about actually containing and directing people to the best possible place, and the interface between digital services, which you'll hear more about from Kooth, but also obviously in-person traditional services within the NHS, which we work very, very closely with. I've also had about 12 years of experience in digital health, and just been, just blown away really by the potential for reach and accessibility. But also with that comes, I think, increased attention in importance of quality and safety. So this will be no surprise to anyone here, I think. Mental health is the defining public health crisis of our time, and I think there's been so much development around the integration and coordination between physical health provision and mental health provision. And I imagine in some of the work that you're doing to support services across the ICSs, and there will be a significant proportion of people both presenting for help, the actual patient, and people around the patient who will be impacted by what is happening to them and for them. We often talk about this in terms of the costs, the economic costs. There's also economic benefits when we get this right. But I think obviously importantly is the human cost as well. And an important part of the work we do at Kooth, and I'll say more about what we do and how we do it in a little while, just to give you some more context, is moving away from reactive provision to something more upstream, more preventative, getting there before things worsen, before people need even more urgent, more crisis care. We have a lot of experience in working with children and young people and with adults, but in terms of what I want to talk to you today about, there's going to be a bit of a focus on children and young people, because we know that the predominance of mental health issues begin before the age of 24. And we also know that healthcare systems globally are really behind the curve in terms of need and provision match. There is a real mismatch. And so in terms of whole population approaches, our experience, and I'd imagine your experience, is that actually if we're able to intervene earlier in someone's life and make a difference and support those who are in the lives of children and young people, actually we can make a change to the trajectory where there is an increasing then burden of care in adult services, etc. And in terms of some of the granularity, again, I'm forever in a way noticing headlines in newspapers and reports coming out that paint in some way a more gloomy, worrying picture of rising demand, rising acuity, rising morbidity, and importantly, more difficulty actually accessing the right service at the right time. And again, I've highlighted the middle point in the slide in relation to some of the thresholds for specialist support. And even I think for some of the sort of support that we would ordinarily take for granted in a way, expect to be there, in relation to people having to sit on waiting lists, not necessarily being seen as quickly as they would need to be seen to actually address the issues they're facing. And actually, some of what we've heard being presented before already, the way in which digital can come alongside clinicians in situ to support productivity, efficiency, effectiveness, reach, quality, etc., both from Stig and Nathan. In terms of Kooth, I don't want to spend too much on Kooth. People may be familiar with Kooth. We've been operating since 2001. We're the largest UK digital mental health provider. We're accredited by the British Association for Counselling and Psychotherapy. And it's available to about 65% of children and young people in the UK. You can see on the map some of our spread and reach across England, Wales, and Scotland. We're the largest contributor to the mental health data set, and we have worked hand in glove with the NHS for over 15 years. I'll come on to a little bit more about our clinical governance framework. Again, it's going to be more of just a mentioning it in a way. If people are interested in that, it might provoke some discussion a little bit later, and something about our outcomes. But we've been around for a long time and providing services where people are able to. We're commissioned usually in sort of as part of an offer to a population, for example, Greater Manchester, where children and young people and adults are able to access our services at really any time, 24/7 through the week, every week, and are able to get access to a range of provision, which I'll show you more about. We've had over 1 million hours of professional support provided in the time that we've been operating, and there are really three aspects, three aspects to the provision we make. We want to grow access, as I said at the very beginning, really remove barriers, provide a safe and stigma-free space. There's privacy, anonymity to some extent, and to be responsive and provide really support that isn't about one size fits all, but actually responds to people where they are in their moment of need. And alongside really for life, in a way, people can engage with our provision and then in a way move away and return at some point. And we're very, very interested in and see as very important some of the health economic outcomes, again, that Nathan was talking to. We've done work which hopefully, if we have time for, you'll see towards the end of the presentation with the York Health Economics Consortium in relation to the impact on the system and the benefits to the system. And you can see here, I often think about Kooth in a way as almost the primary care of mental health provision. It's a big, vast, open door. People come through that door with a whole host of issues and presenting issues, from anxiety through to issues with body image, eating difficulties, etc. And what we're trying to do is actually meet them where they are and in a way support and help them. And also we're very sort of strengths-based as well. It's not just about actually where people are struggling and their difficulties, but what resources and strengths they have available to them. There has been a real shift, I think, in mental health care models from a tier-based approach, stepped care approach, which still is valid and appropriate in many respects, thinking about what is needed at what level, but actually moving much more to the Thrive framework, which was developed by the Anna Freud Center, which we cleave very closely to, which is really 4 quadrants: getting advice, getting help, getting more help, and getting risk support. And even though I've said Kooth is very focused on early intervention, prevention as such, there's a large proportion of our service users who present with very significant issues around risk and safety. So we have a high proportion of users who will present with self-harm. We'll have a high proportion of users who are presenting with suicidal ideation, for example. And although we're not a crisis service per se, and we want to connect in, we do connect into local communities and local provision and are able to signpost where we need to, we take safeguarding very, very seriously, but also about supporting people. So any one person could actually, in a sense, move through those different quadrants, within a very short span of time, actually, depending on the person, their circumstances, the presenting issues, etc. And that's really important in terms of being able to meet people in their moment of need. So to give you just a flavour, and it's not really going to be the depth that Nathan went in terms of the system, and both behind the back end as well as what clinicians and patients and referrers would be seeing. This hopefully gives you some idea of what we're presenting to people to get personalized, effective support. People can just engage with the platform and get self-help. We've got thousands of articles, thousands and thousands of articles that have been written from a professional point of view, but also from a service user point of view that is made available. We have more content and a community, so people are able to engage in discussion forums, and users cannot engage with each other as such, so we make sure that actually users cannot be having side chats, as it were, and actually communicating and relating to each other in a way that would be less safe and less secure. But at the same time, we do take peer support and peer involvement very, very seriously. Everything is moderated when it is developed by a user and put onto the platform. Nothing in a way gets published and available more publicly before it is actually scrutinized and looked at. And again, we are using AI to assist us in that, but there is this real interface with Kooth between the technology and what is available in terms of leveraging the best technology to make us more effective and accessible, but at the same time we have a whole team of people across different functions working to make sure that people are safe and that people get proper support and care. And that includes a large team of practitioners who are working to offer the slide on the screen on the right, the professional support. So people are able to get into a responsive pathway where they can have a drop-in chat, or actually get into a structured pathway where they can actually set up ongoing work with a counsellor, with a clinician. And we have a fairly sizable clinical team. I'm part of their clinical team who are supporting our service lead delivery team to provide care at the front line. I'm going to repeat the slide. You'll see a similar slide, but this is actually our adult platform. It's quell.io. That's for our adults, adult service users, and you can see the nature of the content here is more suited and more curated for adult service users. But I'm going to click across, and you can see over here, this is actually what you would see on Kooth.com, which is our platform for children and young people. Again, the self-help community support, excuse me, and the professional support. And again, that easy access, no assessment or referral required. We just have to be part of a commissioned area. We have that full access, out of hours support, signposting, moderation, all the things I've touched on, and there's a bit more there too. In terms of a little bit of a peek into the future, and I won't dwell on this too much, but we have, since January last year, we've been operating, January this year, we've been operating in the US, in California, where we have launched an app. And actually, the two previous screens show you what looks like an app. Actually, in the UK at the moment, Kooth and Quell are available as web-based platforms. They are mobile-friendly, but it does also mean that within school environments, because actually a lot of our engagement with children and young people is through the schools, that actually people are able to integrate that support into what the mental health and well-being provision that is being made available at school. But actually within California we have launched an actual app called Saluna, and we are now working very, very, very much on learning from that, because obviously Saluna in the US was built on some of the experience that we've had since 2001 in the UK, bringing it back at some point to the UK. And that will be a different interface, but still have the sort of foundation of Kooth UK. Again, just to touch, because I suppose the main part, and I'm mindful of time, and I want to keep to time, although I think I've been a bit ambitious with my slides, is everything we do is embedded in a clinical governance approach. And we've noticed that there's been a real shift, and I think both Stig and Nathan have talked about continuous improvement, continuous transformation, and I think that's absolutely true of our experience and our approach to quality improvement. It's really looking at continuous improvement, looking much more, I think, at the social and environmental factors that influence mental health. And that's been a huge shift in my own sort of work in this area, from being a psychologist who qualified in sort of 1995, where there was such a focus on individuals. If you presented for help, you had a problem, and it was your problem that needed to be sorted out, as opposed to now thinking much more systemically, in a much more kind of complex way about what leads to. So a lot of our work, working in different areas, is about working with local commissioners, local service providers, understanding community benefits and actually how we can strengthen communities. But of course there is something, and we know this from our users, that actually being involved in our platform actually provides another community for them. And that's not to say that we want people to be online all the time and just be sort of stuck on their phones or their computers and not be actually having more kind of real-time relationships. But there's something about using that as a facilitator, as an enabler. So I think there is something here about the power of digital really exponentially increasing reach compared to traditional in-person services, and yet all too often quality can suffer. There are also specialist services that provide high quality but just are not accessible enough. And I think, Nathan, again, you were talking, I think, about bottlenecks, about access, about people not actually getting the help they need at the right time, and all the work that you and I think Stig are doing in your company about improving that. But in a sense, we have an accessibility issue, don't we? I mean, demand far outweighs supply, and we're not going to get much further, I think, just simply with putting more people to the pump in a way, and actually, in a way, just dealing with this as a workforce issue. It's about trying to do things differently. And what I want to go on and talk about is actually the work we've been doing to actually, again, work in a different partnership, more closely embedding pathways between in-person services and digital, and how the two can partner and collaborate with the sort of best possible outcomes for service users. And we have a model, and again, this is a different talk, but I just want to sort of signpost it. If people are interested, they can ask about it or come and talk to us at our stand in the main hall. But an iRespond model, which has been developed as our clinical governance framework. The S, for example, stands for safety. We have a dedicated safeguarding team. Obviously, safeguarding, both for children and young people and adults, is crucial, particularly when you're offering digital mental health at scale. We actually do a lot of audits. So every single chat that people have with us on our platforms is available as data. There is a chat transcript that we're able to audit. So all of our practitioners, for example, are routinely audited on a regular basis to see that actually, through the lens of the iRespond model, we are delivering the best care, the most effective care, the most person-centered care, and the most effective care. Again, this is probably another whole talk in itself if I was just to sort of unpack this slide, but I'm going to move on. Pictures paint 1,000 words. This is really about access. And again, I'm going to focus on some of the work that we've been doing with CAM services in terms of what we've called our integrated digital pathway, our IDP services. And these are a fairly new development. These are things that we're starting to sort of, in a way, work with various partners and starting to sort of develop and learn, and then have a way of kind of embedding and scaling practice. And I want to share some of both what it is we're doing, but also some of the learnings from what we're doing. But it really is about actually leveraging and enabling. Excuse me, I'm just going to get some water. Thank you. Leveraging digital health alongside in-person services. So primarily this has been about working very, very closely with CAM services. In one example, we've been working with the CAM's crisis team. In another example, with a more sort of bog standard, if you will, CAM's team. Helping them with the treatment of their waiting list, the fact that just there are too many people waiting to be seen and not getting the support they need at the right sort of time, and all the implications of that in terms of worsening of the situation, escalation, that when you then actually see people, if they actually wait to be seen, unless they drop out and start to get involved in other kinds of behaviours or situations that are more difficult for them, and for getting help again at a later point. So we've had a crisis step-down support following presentation and post a CAMS risk assessment. We've also worked with within a neurodiversity pathway, supporting people with anxiety and mood management while waiting their diagnostic assessment. These are two kind of key areas where there just isn't enough resource, enough provision, enough supply to meet the demands. And also working within a single point pathway. The two that I wanted, it's quite a busy slide, I appreciate, but it's really giving young people on waiting lists immediate access to professional help. And what can happen is that we can see them and work with them, and they can be discharged from our care and also then discharged from the CAMS team's waiting list, or indeed they can remain on the waiting list and be seen at a later point, or indeed there are then channels for escalation. Well, escalation, as I said before, de-escalation. I'm going to zoom in a little bit because I know it's a bit of a busy slide, but the one pilot that I mentioned is in relation to the Lincolnshire's CAMS Crisis and Enhanced Treatment Team, and that was called the Help to Cope pilot in Lincolnshire. 78% of accepted referrals engaged with the Kooth platform, which I think is really important. We do a lot around kind of warm handover in terms of, and in different areas we do it in different ways depending on what the needs are of those services and how they work, and actually the process we want to kind of co-design and develop that will meet their needs, the needs of their service users, patients, but also how they work already. 100% of young people felt heard, respected and understood. And we do a lot of goal-based outcomes. We've worked with the Anna Freud Centre on developing our goals-based approach, and it's an accepted measure with NHS England in relation to actually helping people make effective change in their lives and move towards improvement and better mental health, better well-being. And then we have the My Support IDP, which was co-designed with the North East Essex Integrated Care Board and the Suffolk CAMS team. Again, 95% of young people referred were eligible, 100% said they would recommend Kooth to a friend, and all young people who completed the intervention engaged with goals and were able to make meaningful change. The interesting point as well that isn't reflected on the slide is actually the impact on staff morale and sense of effectiveness. So actually we created dedicated teams. So of our sort of 300 plus practitioners, we created dedicated teams supported by our service delivery management and supported by our clinical team to actually make provision and work in the service. And there was how we kind of manage referrals, how we engage people, how we do the work, and then in a way how we signpost or indeed sort of close someone's case for that period. And that was really, really important. This is also really important around autonomy and flexibility. So with the Help to Cope pilot, 82% of successful chats took place outside of office hours. With the My Support pilot, young people logged in twice as often outside traditional office hours. And I think that's really important in terms of making provision available when people have the need, experience a need for support and help, as opposed to, as you know, trying to sort of shoehorn people into when a clinic is available. So it's really coming alongside and offering something of a choice. This is some of the range of issues that were presented with. And I just, ahead of today, I had a discussion with the clinical team and with the service delivery team about this, because I said, I'm coming to speak at the conference today, and I wanted to understand from them what they saw as the value to the system, because that is so important. And so it's not reflected on the slide, but I just want to take a moment because I think it's actually, it's really, I think, valuable insights from the people who are actually delivering this work. So it offers a solution to extend the capacity of services and provide alternative routes to support. It takes pressure off services and waiting lists, and while more children and young people can access mental health support at a time of need, providing a digital alternative to more immediate access. And it's flexible and needs-led. And also there's a building of confidence in novel approaches, especially digital ones. And the safeguarding procedures and examples of this have demonstrated the safety in digital care pathways with thought, care, proper frameworks, attention to the guidance, with no challenges highlighted in the safeguarding process. And certainly with the just going to go back, with the Help to Cope pilot, we were dealing with, with people who had very significant issues and challenges, and were presenting with significant risk as well. The differentiating features and functions that I've drawn attention to have proved very, very popular, as well as the elements on the platform that are delivered asynchronously, or in a sense without any one of our delivery team involvement. So that's journals, discussion boards, articles, being part of the community. But the thing that I also want to draw out for you, because I do think it's important, is what are the necessary factors or contributions to make this work? Because again, when there is this interaction with this collaboration between different organizations, but certainly between an organization like ours, which offers digital mental health provision and support and more traditional services, there's a lot of thinking and work that has to go on, I think, to really, really make it effective and make it work. So the process mapping and consultation before a contract gets implemented and delivered, bedding process and buy-in from service providers and training for staff. And I think, again, Nathan, the things you were talking about were obviously at a different kind of level in terms of systems and data and integration. But again, that real opportunity to understand how things work at the moment and how they should work best going forward in terms of this partnership and this collaboration, to build also relationships, confidence and trust in the service and model. And I think it's fair to say that even though we so live in a digital way, in a digital world, I mean, everything from banking to booking a train ticket or whatever it is, we pick up our phones, our computers, etc., all through the pandemic in terms of Teams meetings when I was in the NHS, or Zoom meetings, etc. And we leverage that now even, we still do in terms of making our lives more easier, having more reach, etc. But I think there's still enormous, to my mind, significant skepticism and doubt about digital mental health delivery. And it's not as though questions shouldn't be asked. We should be able to provide assurance. We should be able to show that there is rigor in our approaches, and it's not just anything goes and whatever. But I think there's still, for me, that sense that we've got quite a lot of work to do together to actually build that trust and momentum, because it is different. I think it also requires a robust understanding of the purpose and scope of the collaboration and the integration of processes, as well as your referrals. We've had a lot of issues, actually, and you most probably won't be surprised by this, but by data issues, data governance, GDPR, data flows. And I think we've got more work to do, actually, with how we do that better in a way to ensure that that information can flow more seamlessly, but also that information is more available on different systems that are then able to sort of speak to each other and create more sort of synergy and be more seamless. Definitely when the clinical teams are talking to each other and when there's a strong relationship there, that is absolutely important. I think these things happen because people are prepared and involved and are doing the work. And a willingness to engage in online interventions as well. And as I say, there's more work to be done there. So hopefully that's helpful to you in terms of, I think, some of the learnings that we've got, both about the value, but also actually about the necessary factors, what has to be in place in order to make it work. We have been really working on developing our thinking really about a whole population approach to create value for, and I think this is an aspirational piece really. This is about actually where we want to reach to at some point. I think at the moment, and there's variation I imagine across different ICBs in the country, or where they would see themselves on that scale, from a real focus on individuals having access to the support they need when they need it, the right provision at the right time. But of course also the real benefit of community provision, strengthening communities, because actually we live in communities. And actually if there is provision and support and I think, there've been, I think, real challenges in actually ensuring that local community resources and community structures are in place to enable people to, in a way, be well and ultimately thrive. And then, of course, the work of across health systems, both across providers, within the statutory sector, the charitable sector, with organisations like ourselves, and then in terms of actually a whole population impact. And again, this is work that we're developing, we'll be publishing about, and we want in a way to also get contributions to. This is just to, I've got a few minutes, just to talk a little bit about some of the individual outcomes that have had a positive effect on the social and health system benefits. And just looking at, as I was saying, people presenting with significant emotional difficulties, suicidal ideation, self-harm, behavioural difficulties, seeing after a month, and this is work we did with the London School of Economics and Political Science, after a month of working with Kooth, a reduction in that respect in those areas, but then also working with the York Health Economics Consortium on making a real difference in terms of, I think for every £1 roughly spent, £3 saving. And there's more work to be done here about actually how we properly look at the real sort of benefits and outcomes in the system. It's work that I did in 2009, 2010, when I set up that primary care service that I mentioned at the very beginning. We were again looking at quality of life indicators, and we were also looking at usage. Were people more able to manage in their lives, feel better, be able to do more, and actually be able to either access more appropriate help, because I don't think it's just about not accessing help, not knocking on the secondary care door, but actually accessing more appropriate help, and also at times actually not needing to access any further help at that point. So thank you very much for listening, and again, if anyone is interested, we'll be in the main hall as well. Thank you.